Clinical manifestation could be nephritic, nephrotic, or both. Give me one for nephritic, or give me two. H&H, hypertension, hematuria. What about nephrotic? O, massive loss of protein, or it could be both. Now, the one that you'll be paying attention as we go through this will be type 4. So all I'm going to do is drop down to number 4. On your own time, you take a look at 1, 2, and 3, and 5. Here's our focus. This is your focus, our focus. The prototype under WHO classification for SLE-induced kidney damage is this one. What is it? Type 4. How many letters in DPGN? 1, 2, 3, 4. Yes. 4 letters. Type 4 is DPGN. Now, I had you memorize the D in DPGN is what kind of deposition? Take a look at this in bold, subendothelial. Where are you? Between the endothelial cell and the basement membrane. Are you picturing it? What kind of pattern are you going to find? A granular pattern. This is the prototype, and DPGN could be found with both nephritic and nephrotic presentation. Now, in good faith and good conscience, there's no way that I can move on without making sure that you do know that 10% of the time might be membranous. Is that clear? So every once in a while, say that you've done your nephrology rotation, and your nephrologist was pimping you, and was saying that, well, this is a patient with the SLE, and you find this patient having double-stranded DNA. Do not jump to conclusion, think that it's subendothelial. If you find such a patient and the deposits were subepithelial, then this is SLE-induced kidney damage, membranous type. You've heard of spike and dome appearance. Now, understand, membranous, we haven't even begun the discussion nephrotic yet. All we've done up until this point is discuss important nephritic glomerulonephritis. We went into RPGN. Even under RPGN, where did it come from? Nephritic. Do you understand that? So when we touch nephrotic, guess what? I will repeat our membranous discussion here. Under type 2 RPGN, let's quickly point out some Henoch-Schönlein, or AKA our purpura. Take a look at the legs in our patient. You see those areas where there looks like little red rashes? It's not a rash. It's actually bleeding. Increased vascular permeability because it got damaged. The blood vessel did. How did the blood vessel get damaged? If this patient, if there was a history, and if I'm telling you that this child is also suffering from hematuria, then chances are pretty good that if you were to do a biopsy of this lesion, you would find IgA. Welcome to IgA vasculopathy. The reason that we have this here is because you can have IgA deposition in your kidney, and the reason that we're talking about such vasculitis in the nephrology topic is because of its involvement of the kidney, it may result in RPGN. Where would you find this? Arms, legs, usually lower extremity, buttocks. Systemic childhood disorder. By systemic, we mean other organs could be involved. IgA and IgG are the most common immunoglobulins, and these will then deposit where in the kidney? In the mesangium. Clinical features: pain in the abdomen, vomiting, intestinal bleeding, non-migratory arthralgia or pain, but it's the palpable purpura that you're truly paying attention to because of immune complex deposition. Palpable purpura. You can literally feel the purpura on this patient. Fibrinoid necrosis taking place in your blood vessel. Continuing our discussion of RPGN under type 3, we'll take a look at some of the ANCA positive, posse immune,